Good afternoon. Thank you so much for joining us for We Were There. This session, the We Were There series, was started so that CDC disease detectives could share the lessons that they learned in their investigations so that others may be inspired to carry on their work. Today's session is about how a rare cancer changed the workplace and environment. It was an investigation of polyvinyl chloride in a very rare cancer called angiosarcoma. And now a few words from the Deputy Director, Ann Schuckett.
Good morning, and welcome to the latest installment of We Were There. The first detection of an emerging health concern often depends on an astute clinician, someone who sees something and realizes it's unusual, and then follows up to alert others. That's the case here, when the physician at a chemical plant realized that 3 cases of an extremely rare liver cancer was unusual. You'll hear today about linking these cancers to vinyl chloride gas exposure. In the 1960s and 70s, vinyl chloride was commonly used as a propellant in hair and paint spray. The potential threat was everywhere. Many times the warning that we have a new threat on our hands comes from just a small number of cases. Toxic shock syndrome was first recognized in 7 children, several of them boys. They presented with fever and a severe rash leading to peeling skin. When just 9 children developed intestinal blockage or intussusception after getting the first-generation rotavirus vaccine, RotaShield, the signal prompted a national investigation and pause in the immunization campaign. Small numbers pose a predicament. How many do you need to investigate? How many is enough to take further action? How many when you have no idea what the background or expected rate of an event is? Sadly, the canaries in the coal mines warning us about imminent threats too often are humans. Even worse, for environmental exposures, the workplace may amplify a worrisome exposure and unmask the risk, but at a high cost, the health of people who were only doing their jobs. The story you are about to hear launched a positive chain of events, going from detection to science to regulation to prevention. The young whippersnappers who carried out this investigation are now not-so-young gurus, but their story need not remain in the past. Their work spared many the risky exposures they were investigating, but also spurred continuing research. Fast forward to 2015 for that recent report on the discovery of the genetic mechanism by which exposure to vinyl chloride produces cancer mutations. Or to 2016, when a study of vinyl chloride metabolites in workers linked the metabolites directly to fatty liver. This finding goes beyond vinyl chloride to validate the new science of metabolomics for the study of many different kinds of chemical exposures. The We Were There series reminds us that we at CDC are part of a continuum of scientific discovery. Learning from the past can help us create a healthier future, and each of us is challenged to up our game and incorporate the best insights from these landmark investigations that helped make CDC the trusted agency we are today.
It's my pleasure to invite up the first young whippersnapper speaker we have today, Dr. Henry Falk.
Thank you very much. So this talk is about an investigation that I actually began a little over 44 years ago as an EIS officer. It's about a rare type of liver cancer known as angiosarcoma, which was very rare, very obscure, but very fatal, and a disease that it caused in people who polymerized vinyl plastics. So this actually had a dramatic impact for a number of reasons. One is that virtually everybody had these PVC or vinyl or polyvinyl chloride plastic products within their home. Dr. Schuckett just mentioned hairspray, but in those hairspray containers that people were using back in the early 70s, it would say active ingredient 1%, inert ingredient, which was the vinyl chloride, 99% of the product. Everybody considered this safe, and so this came as a shock in that shattering the illusion of safety for these types of chemicals. As Ann said, it's not possible to predict the evolution of a new disease. And it raised many questions about, was it more than just this plant? What about people who live near the plants? What about people who use the products? What about other kinds of chemicals that were fairly similar to vinyl chloride? There were just many questions that came out of this cluster investigation. So we were there. I was there, but how did I get there? It was a very unintended career. I finished medical school at the height of the Vietnam War, was drafted and sent off for a pediatric internship or residency, and then was assigned to the CDC because the Army needed epidemiologists. I matched with a cancer branch. I wasn't heading for a career in infectious diseases. I thought it might be interesting if they somehow discovered a cause of cancer while I was there during those 2 years. There was really, except for Phil Landrigan, nobody was doing environmental epidemiology at CDC at the time. NCH didn't exist. NIOSH wasn't even part of CDC, and EPA had only recently been created. So my assignment was at Texas Children's Hospital in Houston. I was asked to investigate a number of cancer clusters, and those were all negative investigations, didn't find any infectious causes for them. But I was stationed in the petrochemical capital of the United States in Houston, Texas, and all you had to do was look around, and there were chemicals everywhere. So on my own time, I started taking courses at the School of Public Health at University of Texas in chemical carcinogens, environmental factors. I did a paper on asbestos and mesothelioma, and essentially I was the only person in the epidemiology program with an interest, I think, at that time in chemical carcinogens. So when this request came for the NIOSH assistance and the EpiAid for the cancer cluster at the B.F. Goodrich facility in Louisville, Kentucky, I, who had never done an occupational health investigation, never had seen the inside of a chemical plant, there I was with the NIOSH team. So this cluster was a wildly improbable event. There are 27 cases per year of this disease at that time in the entire United States. So 4 cases at one plant had a relative risk which was somewhere above 6,000. Nobody expected this. The alert chemical plant physician that Ann Schuckett referred to said it to me this way. When he saw the first case, it was unusual. When he saw the second case, he was getting anxious. When he saw the third case, it was like he had seen 3 straight patients walk into his office with red, white, and blue pimples on their nose. Had no idea what the problem was, but knew he had a big problem. So I joined the NIOSH team. My original focus was to verify the cases. When you're doing cancer cluster investigations, until you verify the diagnosis, you really have nothing to work with. So just so you understand kind of the process here and what we were dealing with, so in the upper left-hand corner is vinyl chloride. It's basically ethylene compound with a chlorine attached to it. When you cook it up in those kind of reactor vessels that you see in the middle of this slide, they're like 15,000 gallon pressure cookers. You end up opening the double bond and you create the long chain, which is a polyvinyl chloride or PVC. And depending on how you actually do that and what chemicals you add to it and what plasticizers are there, you either get a very flexible chemical like a saran wrap or you get a very rigid chemical like a PVC pipe. The toughest part of the job here and the place where there was the greatest exposure to vinyl chloride is that people had to be lowered in through the hatch you see at the top of these tanks to clean out the inside of the tanks between vessels. They basically scraped out the inside of the tank. They were lowered in buckets often because these are big tanks, as you can see, and very often people were anesthetized and put to sleep while doing this work. They were exposed to such high levels, they had to be carried out with their bucket. So again, just briefly, the production of vinyl chloride monomer is a closed system, limited exposure. At the bottom, producing products from the plastic itself has very little vinyl chloride monomer exposure. It was a polymerization process itself with the cleaning out of the large vessel reactors that was a really hazardous part of this job. Now, just to show you the key dates, the plant opened in 1942. first reported cases of hepatic angiosarcoma were in 73, 74. But there was yet another rare disease seen in these workers called acroosteolysis, which is, as it says, holes at the end of the bones. And I think you can see it if you look at the end of the middle digit finger, you can actually see a hole in that bone. There's a black spot in the middle of that bone. Unfortunately, this was interpreted as a very localized lesion, probably related to the constant scraping and trauma to their hands. Wasn't seen as possibly systemic in nature, so it didn't lead to a reduction of vinyl chloride levels that these people were exposed to. It led to better care for their hands as they were working. So this is the description of the first 4 cases in the original MMW article. And there are 3 things I'd like to point out. One is the years of PVC work. These people had worked on between 14 and 27 years, these original 4 cases. But if you look at the date of diagnosis compared to date of death, 2 were only diagnosed at autopsy, and there's a very short time frame between diagnosis and death. And if you look at the columns between date of onset and date of diagnosis, again, except for 1 patient, a very short period. These people had a silent disease and near the end progressed rapidly to diagnosis and death. So this is from our next report, which was in JAMA and covered 11 cases, 7 cases of hepatic angiosarcoma and 4 cases of what was a non-malignant hepatic disease, a precursor lesion that went along with this. And it's interesting to point out, if you look at the dates of diagnosis, there were 4 cases that actually were diagnosed in the 64 to 70 period, but it seemed to be rapidly increasing with 7 cases during that last 3 years. The initial symptoms were just fatigue, weakness, weight loss, nothing specific. One of the patients came in for a hernia repair. They noticed the elevated liver. So there was very little to go by in terms of signals that disease might be developing in these workers. And this is a result of our sort of quick and rapid analysis of the work histories of those original 11 cases. And Dick Lemon, who's following me, will give you the much more precise version of this from the cohort mortality study. But as you can see in the top line, these people had worked on average 17 years in that most heavily exposed job, cleaning the PVC polymerization reactor vessels. They had a smattering of time elsewhere in the plant, but there was nothing common about the places where they worked outside of the polymerization buildings. And the largest majority of people who worked elsewhere in the plant, none of the cases had actually worked in those part. So it was very clear, even from the very beginning, that the vinyl chloride monomer exposure was the critical factor here. So we were very interested in how this disease developed. And one of the things I did is went back and get pathology specimens from people who had ever worked at the plant and had a liver biopsy or an autopsy for any reason. If somebody had been in a motorcycle accident after 9 years at the plant and was autopsied, I had the liver specimen. So we could array these specimens over the lifetime of the workers and actually see how the disease developed. I worked closely with the director of pathology at NCI and with arguably the world's best liver pathologist, Hans Popper, who was just happened to be visiting Dr. Thomas the day I walked in with my trove of specimens. He was one of the heroes of my life, a great person to work with. We looked at thousands of slides together over the years. So when I arrived, he said, "Show me a slide." Put on a slide of the tumor. He said, "Show me another slide." Put it on. He said, "Angiosarcoma, no question. Show me the rest of the liver. What does it look like?" Showed him one slide. Show me another. Second, showed him another. And then he was a little shorter than me. I have never actually seen the light bulb go on in somebody's head quite so clearly. He literally bounded out of his chair, almost shouting that this was Banty syndrome. He had seen it in Africa 50 years before, so it was an exciting moment for him. But he actually understood the pathogenesis. So this was the sort of an original portrayal, this figure of what we were seeing. There was activation of the sinusoidal cells, which are the vessel lining cells in the liver, activation of the hepatocytes, and sinusoidal dilatation. That was the precursor lesion. It could extend to angiosarcoma. The hepatocyte proliferation might have extended carcinoma. It didn't in people, but it did in rats. And then in the top, you see that it could extend through hepatic fibrosis, portal hypertension, and splenomegaly. And if you look at this from under the microscope, if you look at this on the left, the straight arrow is pointing to a somewhat dilated hepatocyte with 2 nuclei. The curved arrow is pointing to so activated. These are normal-looking sinusoidal lining cells, but there are 3 of them heaped one on top of the other inside the sinusoid. And in general, these sinusoids are more dilated, larger than you would expect. If you look at the photo on the right, the sinusoids are much larger. The lining cells are very anaplastic and misshapen and clearly malignant. And the arrows are pointing to actually very unusual hepatocellular cells that have fat globules and other things which are unexpected. So you can see the contrast in how the tumor developed from the precursor lesion. So the liver disease in these workers was very atypical. At this agency and really all through occupational health, infectious diseases, classic hepatotoxicity comes where the clinical signs and symptoms appear early, there are enzyme changes, lots of laboratory tests are abnormal, the functioning of the cells is abnormal, and most hepatotoxins function like that. What we were seeing was a silent progression. The function of the liver cells didn't change till almost the end. There were no simple and effective screening tests for the workers. And in fact, we did a study at a PVC plant in Pottstown, Pennsylvania, and found almost nothing except a small percent with a very modest increase in liver size. So this is actually, I think a remarkable event in the annals of occupational medicine, and Dick Lemon is going to go through this in more detail. But within a year or two, through the work that we had done, through the NIOSH cohort mortality studies, through the experimental work that corroborated this disease in animal studies, the link was demonstrated very clearly. And as a result, the regulatory fix came very clearly, and the permissible limits were lowered from 500 parts per million of vinyl chloride monomer to 1 part per million. And the occupational cases tapered off over the next decade, and over 20 or 30 years, they pretty much dwindled down to almost nothing. FDA and EPA did their bit for food packaging and environmental regulations. So at this point, I could probably have gone home, felt that I had done my job well, and just called it a day. But we being in Atlanta, right, we thought that we could add to what NIOSH was doing by conducting surveillance for angiosarcoma of the liver. Maybe we would find cases at other plants that weren't being studied. So we did a death certificate survey, a national search, miscellaneous liver tumors. You have no idea what an EIS cubicle looks like with 22,000 paper certificates in them. But the shocking thing to me was that we always expected that who would know about hepatic angiosarcoma? We anticipated a lot of false negatives. But I never suspected that people would go to great lengths to call something hepatic angiosarcoma when it wasn't. But less than 50% of the cases that we retrieved from the death certificates could actually be confirmed as hepatic angiosarcoma. We didn't find any more from PVC workers. There was a false cluster that turned out to be nothing. And in the end, we discovered that only 23% of cases could actually be diagnosed on the death certificate. So we concluded you couldn't study this rare disease by looking at death certificates. So we went on to the pathologists. We sent a mailing to all the U.S. pathologists. We collected specimens from the files of the Armed Forces Institute of Pathology. We got pathology specimens in all published cases. We wrote to tumor registries. And we identified a total of 168 cases, still with many false positives. But I suddenly just realized that we had 4 cancer clusters that we were investigating because there were 3 other likely causes that were identified: thorax rest, arsenic, and androgenic anabolic steroids. And together with the vinyl chloride, 75% of the cases were still idiopathic. So just to go through these one by one, Igas Moniz, whose picture you see, got the Nobel Prize in Medicine in 1949 for doing the first cerebral angiograms. And a year later, a German group improved on his technique by coming up with a better contrast medium, which was thorotrast, a colloidal suspension of thorium dioxide. Thorium is very similar to uranium, and what people did not realize in the early days of radiation science was that the thorium went to the liver, stayed there for the life of the patient, and radioactively decayed for the entire life of the patient. You see, the figure is from a New England Journal of Medicine case study in 1981, and the arrows point to the actual alpha particle tracks in the liver, which are picked up by a special histologic technique. And of course, whatever cells happen to be in the path of those alpha particles could turn malignant. So these thorotrast recipients actually develop angiosarcoma, bile duct carcinoma, hepatocellular carcinoma. This was primarily in Europe and Japan. There were maybe 5 to 10 times as many malignant tumors that resulted from thorotrast as from vinyl chloride. Had rarely been reported in the United States. People, kind of thought we were doing pretty well. But we identified 25 cases and reported on them, and clearly this was something that had been going on, probably unreported in the U.S., and I was seeing the end of this outbreak. So the second cluster related to arsenic. So arsenic is a known carcinogen, skin, lung, and bladder. The NCI and NIOSH have also concluded that it's a hepatocarcinogen. And historically, there have been multiple case reports and small case series of angiosarcoma related to arsenic going back to the early part of the last century, from pesticide exposure, from drinking water, and from something called Fowler's solution, 1% potassium arsenite, which was used in the first half of the 20th century for treating asthma, psoriasis, and other diseases. We found 7 cases, 4 of whom were related to the last clinic in the U.S. still treating asthma patients with Fowler's solution. And then finally, we saw 4 cases related to androgenic anabolic steroids. These substances cause classic hepatotoxicity. They cause cholestatic jaundice. They also had been reported to cause sinusoidal dilatation and an extreme form of blood filling in the liver called pileosis. And the 4 cases we saw were actually filled in the blanks in this figure. So in the center, you see the core precursor lesion for the angiosarcoma, and some of the substances that can cause angiosarcoma, like thorotrast, caused only some of the outcomes, like cancer and angiosarcoma. But with these cases, basically androgenic anabolic steroids were seen to relate to all possible outcomes from this precursor lesion, including adenoma, pileosis, carcinoma, and angiosarcoma. So we actually postulated that it would have been interesting to have set up a rare tumor registry before the vinyl chloride episode. And if somebody had been able to do this efficiently from multiple kinds of rare tumor markers, we might have picked up the vinyl chloride episode sooner. There are 3 reasons why one would have thought about studying hepatic angiosarcoma. There was a history of thorotrast and arsenic in humans. There are multiple chemicals that cause this disease in animal experimental studies. And these tumors occurred in younger people with predominantly males, suggesting occupational exposure compared to other sarcomas of the liver, like fibrosarcomas and liposarcomas and so on. So maybe if we had been looking at the rare tumors, we might have picked this up a few years earlier. So the final part to this investigation brought me from PVC plants to meat wrappers, asthma, and supermarkets. So my wife was 7 months pregnant as I was going around the country from one vinyl chloride plant to another. And at one point we decided that I needed to be home. And I was trying to figure out, how do I tell this to my supervisor in Atlanta? And so what happened is a woman walked into the Harris County Health Department, said she was a meat wrapper, she had asthma, she was waving the paper of that day's Houston Chronicle, which had reported a summary of an article from the journal that actually described the first few cases of meat wrappers' asthma. that had been seen in the country. And so when you go to the supermarket, you can see this in these photos, which are their current photos. I don't have any photos from 1974. The meat in a supermarket sits in a styrofoam dish, and it's wrapped from a huge roll of a saran wrap kind of a material. And the challenge in 1974 was how you actually cut the saran wrap, because it clings to a scissor. So they used like a 600 degrees centigrade hot wire. They would just pull the wrapped portion across the hot wire. It would sear the plastic, but there were shards of plastic that were left on the hot wire. And the women doing this work spent all day breathing the fumes of burning plastic, which is toxins, allergens, irritants, hydrochloric acid. It's probably a very nasty mix. And so with Ben Portnoy, who was the EIS officer at the health department in Houston, we decided that people who actually have asthma can't do this work. They quit. So we went off and did a study of existing workers in 152 supermarkets, which took me exactly to the point of the birth of my first son. And what we found was the meat wrappers, compared to the controls, had increased numbers of respiratory symptoms, illness, days off from work, and so on. And so this was sort of the final piece in the PVC study. The film wrap here is what was considered a copolymer. It was PVC usually mixed with polyvinylidene chloride or polyvinyl acetate. And there was a class action lawsuit for $284 million. The supermarkets figured out how to do this safely. And by the end of this, I realized that I'd probably contributed in some way to helping 100 to 200,000 meat, lettuce, cabbage, and other wrappers, the tens of thousands of PVC polymerization workers. Kind of did a mental calculation of how many pediatric patients I would have to see to get close to 250,000, how long that would take. And I ended up, of course, staying as CDC. I was the last of my class of 72 still here, even 15 years ago. I love, the science, the prevention work, the variety of issues we dealt with, people at CDC, the policy issues. I succeeded Phil Landrigan as Special Studies Branch Chief in 1980, president of the creation of NCH, and still hanging in there. So a lot to be grateful for my time here at CDC. So with that, let me introduce Dick Lemon. Dick was a deputy director of NIOSH and also acting director of NIOSH. He happened to be in Cincinnati during those years when we were doing this work and had a very bird's eye view of what we were all about and very familiar with all that NIOSH and OSHA achieved. So thank you.
Thank you, Henry. And it's good to be back in CDC. I haven't been back for a long number of years, but things have changed a lot. How did I get into this? Well, I began my career as a sanitarian for the Missouri State Department of Health. And as you know, a sanitarian is an inspector. We did hotels, motels, food establishment, etc. And then as Henry happened to get drafted, so did I. And I became a medic in the U.S. Army. And it was through that experience that I got interested in epidemiology. And so after I got out of the Army, I joined the U.S. Public Health Service in the Commissioned Corps. And at that time, NIOSH didn't exist. It was called the Bureau of Occupational Safety and Health. And 6 months later, NIOSH came into being under a new law called the Occupational Safety and Health Act of 1970, which created NIOSH, and in the Department of Labor, the enforcement agency called OSHA. At that time, there were 2 trained epidemiologists in what was now NIOSH, and I was one of them. And we now have quite a few more epidemiologists in NIOSH than when I first started. And as Henry said, I worked my way up to deputy director and acting director of the Institute before I retired. And currently, after I left, I went over to Emory and taught occupational and environmental health for a few years. And I currently am on the Presidential Advisory Board. President Obama appointed me on radiation and worker health, which I've been active on for the last 10 years. I'm going to repeat a little bit of what Henry said, but vinyl chloride is the main ingredient in the plastics industry. And it was first discovered in 1835, and Henry has gone through the formulation, so I won't spend time on that. It's normally in the gaseous form, but shipped and stored under a liquid under pressure. It was used to form large molecular chains, as Henry talked about, of PVC, and polyvinyl chloride is produced by the polymerization of vinyl chloride monomer. As Henry discussed, I won't spend much time on this. However, unreacted vinyl chloride remains up to 8,000 parts per million after the polymerization process, which is a large amount of vinyl chloride. It's synthesized from hydrogen chloride and ethylene using mercuric chloride as a catalyst. The production increased dramatically during World War II, and the early stages of toxicity of vinyl chloride were then beginning to be recognized. In the 1940s, during World War II, it went up to 7 billion pounds per year due to the limited rubber supply coming out of the rubber plantations from Asia and other parts of the world. The first recommended exposure was at 500 parts per million based upon its anesthetic effects. And this was done by a conference called the American Conference of Governmental Industrial Hygienists, which was a group of industrial hygienists that worked for federal, state, or local governments at that time. And Henry has discussed in the 1960s the acral osteolysis, a rare bone disease occurring among the PVC reactor cleaners, and also some cutaneous lesions, collagen disease, and Raynaud's syndrome. Adverse human effects, as I mentioned earlier, were basically at that time known mainly because of its anesthetic and anesthesia type properties. Exposures during this time were poorly controlled in the plants. They were up in the thousands of parts per million. In the 1970s, PVC number 2 plastic in the United States. It was a very widely used and popular plastic, as Henry has alluded to, and we in the United States did about 25% of the world's production. There were 14 plants employing about 1,500 workers. There were 37 plants in the PVC production employing about 5,000 workers, and there were hundreds of thousands of workers involved in the compounding and fabrication. It was Dr. Viola in Italy who first produced tumors from high exposures in animals, but they were not angiosarcomas. They were skin and ear canal tumors found in rats. OSHA, as a result of what was known to that point in time as one of their original standards, in 1971 adopted what the ACGIH had proposed, the 500 parts per million, as the exposure limit to be allowed in U.S. plants. Cesare Maltoni, another Italian, and you'll hear more about him from Dr. Landrigan, was the first person to produce tumors, even including angiosarcomas of the liver, in animals at much lower concentrations, at 50 parts per million. And now I'm going to take you kind of on a chronology by month and year by year over the next couple years of what really happened when we started the investigations. Before the angiosarcoma was even noted, NIOSH published in the Federal Register a request for information on potential hazards associated with occupational exposure to vinyl chloride. And then in May of that same year, the Federal Food and Drug Administration banned the use of packaging alcohols in polyvinyl chloride because they found it was leaching into the alcohol that was being consumed. So this was a major development. But in January of 1974, that's when we were notified about the 3 deaths at that time that occurred in the B.F. Goodrich plant in Louisville, Kentucky, from angiosarcoma of the liver. NIOSH did an immediate industrial hygiene survey of that facility, and NIOSH and CDC, as Henry talked about, organized a surveillance network to follow through on other cases and distribution of cases of angiosarcoma of the liver among PVC workers in the United States. In February of '74, NIOSH and CDC held a briefing of all federal agencies with an interest in this to talk about, by that time, 4 deaths from angiosarcoma of the liver. And during this briefing, we discussed how rare this was. Henry talked about this, but 20 to 30 cases were occurring in the United States per year at that time. And we had concluded at that time that this was a new occupational disease that was associated with exposure in the manufacture of polyvinyl chloride. There were 4 working groups that were convened in the U.S. government as a result of this meeting. The first being on epidemiology, the second on toxicology, and the third on industrial hygiene, and finally a fourth on analytical methods. So this was how the federal government was setting up to address this new occupational disease. On February the 9th of 1974, clinical descriptions on several cases of angiosarcoma were now being published, as Henry talked about, in the MMWR, and also an article in the Journal of the American Medical Association. So we were getting the word out that this was a new condition to alert physicians and other clinicians to be on the lookout of potential persons and their practices that may have exposure to vinyl chloride in the polymerization process. OSHA, our sister agency, held an informal fact-finding hearing on possible hazards of vinyl chloride manufacture and use. And then, at that time, Cesar Maltoni, the man that I talked about earlier that had experimented on the lower exposures at 50 parts per million, actually came to the United States to address that hearing and to discuss the finding of angiosarcoma in the rat studies that he had done at that time. Well, the first director of NIOSH, Dr. Marcus Key, who I can say is still alive today and remembers this, I think, fairly readily. Dr. Marcus Key was the director of NIOSH, and he addressed OSHA, saying that at this time there was no safe exposure concentration that we could find at NIOSH for vinyl chloride. And there was no odor threshold for vinyl chloride, so it wasn't readily detected by the workers. Workers were warned to wear air-supplied respirators anytime they were exposed to any concentration of vinyl chloride. And the current level of sensitivity for monitoring through the analytical methods that we had at that time were 1 part per million. But this, Dr. Key stressed, should not be considered an acceptable level, and all workers at this concentration should be wearing respirators. Well, on May 10th and 11th, the New York Academy of Sciences convened an international working group on vinyl chloride. And many of the luminaries on vinyl chloride came to that meeting to discuss their findings. As a result, NIOSH proposed a standard for vinyl chloride. And in June of 1974, Dr. Key addressed this and reiterated that there is no safe exposure limit that could be found. He reiterated that the current analytical monitoring method sensitivity was down to 1 part per million. He stressed that all workers working with vinyl chloride be afforded respiratory protection. And if NIOSH decides to set their permissible exposure limit at 1 part per million, this should not be considered safe. It only should be considered acceptable. So the exposure measurements that NIOSH was finding when we went out throughout the United States looking at exposures to vinyl chloride were between 0.3 and 12 parts per million in the United States. The time-weighted average was estimated in the working places that we surveyed to be about 2 parts per million at that time. But the problem was we were seeing peak concentrations getting up to 300 parts per million. And who were the people most at risk? It appeared to be the maintenance and repair workers that were experiencing the highest exposures. Angiosarcoma cases associated mainly in those that worked in the reactors and the vessels where the reactions were occurring. You saw those pictures that Henry showed earlier. In June, Dr. Key testified and to Congress, and he talked about NIOSH and the Department of Health, Education and Welfare, now the Department of Health and Human Services, had set up a committee to coordinate toxicology and related programs to define procedures for designing animal studies to determine the carcinogenic risk, since at that time did not feel that the European studies or other U.S. animal studies to date had been either too small or lacked statistical validity to project no effect levels. So the purpose was to try and determine if there was a no effect level. He informed OSHA that NIOSH CDC surveillance had identified by June of 1974 18 cases of angiosarcoma of the liver in PVC workers, 1 case in a vinyl chloride monomer production worker. 13 of those were in the United States, 6 were from other countries. The average age of those workers was 48 and a half years, and the average latency was about 20 years. 2 new cases in workers using PVC in fabrication were also identified. Dr. Joseph Wagner. Dr. Wagner was the first head of epidemiology at NIOSH. He was a Harvard-trained epidemiologist and had come to NIOSH from the National Cancer Institute. And he followed Dr. Key's testimony to the Senate and identified where these cases were occurring in Germany, Sweden, Norway, and there were 2 cases that we were awaiting details at that time from Czechoslovakia. The rest of the cases identified around the world were from the U.S. It was interesting in Dr. Wagner's testimony that he also talked about angiosarcoma of the liver found among non-vinyl chloride PVC workers. In the United States, we saw a case of an accountant, as you can see, 47 years old, who worked in a vinyl cloth plant. Those are plants that use PVC to make vinyl cloth wall coverings or tablecloths or things of that nature. Another case in West Germany in age 40s also was a person that filled pesticide cans with vinyl chloride propellant. As you heard Henry talk about its use as propellant in hairspray, it was also used in pesticides. And a third case occurring in another vinyl chloride or a vinyl cloth plant. I don't know, and we didn't know at that time exactly what the job of that individual was. And the last case in Sweden was among a vinyl monomer production plant worker. Well, workers at potential risk. At NIOSH, we did a survey between 1972 and 1974 called the National Occupational Hazard Survey. We sampled 900,000 workers at 4,636 facilities, an unheard task at that time, but we had industrial hygienists spread across the United States, living out of suitcases, taking these samples. What did we find? We estimated that there were 27,000 workers with definite exposure to vinyl chloride and another 2 million plus potentially exposed to vinyl chloride. Now I'd like to switch and talk a little bit about our cohort mortality study that was done at NIOSH, and Dr. Rick Waxweiler, who is here in the audience, should be telling you about this because it was really he that spearheaded this study, but I'm so glad that he's here today and can address this maybe if we have questions at the end. But we did a study of 1,294 workers, amounting to about a little over 12,000 person years, almost 13,000 person years, from 4 plants with at least 5 years of exposure as of the 31st of December of 1973. 89% were alive, 10% were deceased, and less than 1% were lost to follow-up. What did we find? Well, we found that all cancers were significantly in excess as compared to the other causes of death you see here from heart, non-malignant respiratory disease, etc. If you look closer at the cancers, the all-malignant neoplasms category, you can see that as the latency went up from 10 years to 15 years, that also the significance or the standard mortality ratio went up. And so we were seeing a dose response reaction occurring. We saw a significant excess of brain and central nervous system cancers, also respiratory system cancers, and if you look at the liver cancers and the biliary cancers, you'll see a very significant excess of death. If we look at the 7 angiosarcomas of the liver that were found, you can see the distribution of age, the total exposure. All of these were, with the exception of one, were greater than 10 years of exposure, with latencies all greater than 15 years of exposure. So we're seeing this dose response, but we are also seeing, as we usually see in occupational cancers, a latency period occurring from onset of exposure to the development of disease. Also in the study, found angiosarcoma of the gallbladder, or the common bile duct, gallbladder cancers, and adenocarcinoma of the common bile duct. And there were 4 people that were not in the cohort, but they were found to be alive in the plants that were diagnosed with angiosarcoma of the liver at that time. If you look at the exposures, you'll see that the highest exposures were occurring in the reactor area and the operators, as well as the helpers that were working to help the reactor operators, because the reactor operators actually, when they would go in after the process was done, would have to go into the reactors and actually clean out the inside by chipping out and high pressure hoses to wash out the reactor vessels to make them usable for future use. You also see there was a high exposure occurring in the drier area. But if you look at just other operators or baggers or maintenance areas, the exposures did not peak to as high as we saw in these areas where the actual cases were coming from. If you look between 1975 and 1976, you'll again see that we had exposures in the reactor and operator charging areas, but we found a new finding of bagger and reactor cleaners, where if you broke it down, it was really when they were cleaning that this exposure was exceptionally high. When they were working outside, it was an enclosed process, so they were not getting the exposure to the fumes. Again, this led us to looking at what were the differences between the monomer plants, the polymerization plants, and the fabrication plants. Well, we were seeing the greatest amount of disease in the polymerization plants, and as you can see from this table, that the concentrations were highest again in the reactor area and in the dryer operator area. So this gave us a little bit more clue to where the cases were occurring and where we needed to concentrate our efforts in trying to stop this disease from occurring. So now we were concentrated from the data on the reactors and the reactor cleaners being those highest at risk. But let us look what happened after 1974. The picture was that these concentrations were extremely high, most of them, a majority greater than 5 parts per million. But as we started instituting the OSHA standard and getting the word out that we needed to reduce these exposures down to the 1 part per million, the lowest analytical level, you'll see from 75, 76, 77, these exposures went down precipitously. So we were making progress on getting the exposures down. And that was a result of the OSHA standard that went into effect in the late 1971. Now, an update was done in 1989 of the Weiler study. And it's interesting that the findings in this update added another 13 years of latency. And what they did was to conduct a nested case control study of the vinyl chloride monomer, the PVC dust, and butadiene that was found in this plant. But we were interested more in the VC monomer and the PVC dust. And what they found in updating this study was a strong dose response between the vinyl chloride monomer exposure and liver cancer. But what we didn't expect to find was that while this held for the angiosarcoma of the liver, it didn't hold for the other liver cancers that were in excess before, significantly in excess, after you added more latency and took into consideration the exposures. This kind of washed out, so we were seeing some progress being made. The previous findings of lung and brain cancer were not supported in the new analysis. And why was this? Well, Wu suggested this could be due, one, to the standard that was put in effect by OSHA that became effective in 1974, or at least they could have maybe been attributed to the 19 other chemicals that we identified in the plant in the original study, but weren't, as far as this study could tell, associated with the vinyl chloride monomer, or could be due to difference in smoking habits because these were not controlled for. Interestingly, in May of 1976, the state of Ohio looked at a worker community around vinyl chloride plants and started identifying congenital malformations of the central nervous system in residents that were near these plants. In September of '78, as a result of the NIOSH study and the findings to date, NIOSH and OSHA issued a joint current intelligence bulletin. This is something to get the message out quickly, but what NIOSH did and OSHA did was to look at vinyl chloride and put it together with other vinyl halides like vinyl bromide and vinylidene chloride and recommend as a precaution that all of these be treated as potential carcinogens because of their structural similarities, of the animal studies that had produced angiosarcoma of the liver and other cancers in animals to all of these compounds. So finally, today, we're living still with the 1 part per million standard. We haven't improved our analytical methods that readily, but the current OSHA standard is that vinyl chloride be controlled to 1 part per million as an 8-hour time-weighted average, and for a 15-minute sealing, it not exceed 5 parts per million and be treated as a carcinogen, and that protective clothing and respirators be used and authorized personnel only allowed into the work areas. So this is a quick survey of what NIOSH and CDC did in identifying where the hazard was occurring, who the people that were being affected by this hazard were, and where we needed to concentrate our preventive method on and reducing and preventing further exposures from this particular carcinogen. Thank you very much. Now I'd like to introduce Dr. Phil Landrigan, who is a longtime colleague and researcher. And Phil came to NIOSH from CDC. I think he'll probably tell you a little bit more about that, but headed up the NIOSH epidemiology program. So it's with pleasure that I introduce Dr. Landrigan.
Thank you, Dick. So I want to start by thanking Phoebe for having invited me to come here to do this talk, and say especially to my former mentor sitting here in the second row, Lyle Conrad, how transformative my time in EIS was. I came here pretty much straight out of a pediatric residency, very similar background to Henry. He was from New York, I was from Boston. The Vietnam War was going on. All male physicians were subject to the draft, 2 years national service. Most of my colleagues ended up in the Army, some in the Navy and the Air Force. And I was almost taken by the Army. I was interning in Cleveland, and I got called down to the Cleveland Federal Building to take a physical exam. And then I got a call from Michael Gregg, who was then the deputy director of the EIS program, and he asked me if I was in a place where I could raise my right hand. It was sort of like one of those preachers that heal people through the radio. And I in the intern ready room at Cleveland Metropolitan General Hospital, I was sworn into the U.S. Public Health Service, the EIS. And then I asked Mike if I could have 2 more years to do a residency. He said, sure, we're over full this year anyway. So I went to Boston and finished my residency. I came here in April of 1970. I was thinking as I drove in from the airport this morning that it was about 48 years ago this week, give or take a week or two, that I made the first passage from the Atlanta airport up to Clifton Road, a long time. And I got here knowing nothing about epidemiology. I remember coming in for the EIS conference, hearing people talking about the denominator, and trying to remember if that was the top or the bottom of the fraction. I matched with the immunization program. My supervisors were the late John Whitty and Lyle Conrad. And for the first couple of years, my job was basically to investigate measles and rubella outbreaks. The vaccines existed, but they were quite new. I think the measles had come out in '67, if memory serves me correctly, and the rubella a year or two later. So there were still questions about how firm and how durable was the immunity. I had a very interesting epi-aid up in Olmsted County, Minnesota, that's Rochester, where the county health officer had followed the British tradition of vaccinating only the girls because they were afraid that the immunity might not hold, and the whole goal of rubella vaccination, you'll recall, was to prevent congenital rubella syndrome. So he vaccinated girls who were hitting puberty, didn't bother to vaccinate the boys, and so we had an epidemic of rubella where 90% of the cases were in boys. I had a measles epidemic in Texarkana, which is a city bisected by the state line between Texas and Arkansas. And again, it was a very bizarre situation. 90% of the 600 cases were in Texas. And the answer, it turned out, was that Arkansas, even though it's a southern state, has always had a fairly strong populist tradition. Think of Bill Clinton. They had a very aggressive public vaccination program. Texas was Texas, and you had to pay $10 or $20 to see the doctor, which meant poor people didn't get vaccinated, and there was a large pool of unvaccinated children. And then probably the most important epi-aid, at least in terms of my own life course, was going out to El Paso, Texas, which is where I first met Henry. We had gotten a call, I think it was Lyle that took the call actually, from Dr. Barnard Rosenbloom, who was the city county health officer in El Paso. They had just stumbled over the fact that this big smelter, which had been there for decades, in just 3 years before our epi-aid, had released all these tons of heavy metals into the air in El Paso, Texas. The prevailing legend at that time was that lead from smelters was not a hazard for children because it came through the air and it didn't really hurt them. But we were worried, and so we went out there, Steve Gelbach and I, and then Henry joined us a bit later, and we did first a pilot study in a little local nursery where 90% of the children had blood levels over 40 micrograms per deciliter, which was then the limit. Today, of course, it's 3.5. But they were elevated. That prompted a big investigation. And this was a transitional time for CDC. Just the year before, the name had changed from the Communicable Disease Center to the Centers for Disease Control, same initials. And the only tools we had were the tools of infectious disease epidemiology. So we were applying infectious tools to look at an outbreak of chronic disease, much as Henry did in chasing down the vinyl chloride and peeling that onion layer after layer. This was a similar story out here. And we did big surveys out there. We documented a major point source of lead poisoning, we went on to do studies showing that the children who had elevated levels of lead had neurological deficits even in the absence of clinical symptoms, which is a very important finding at the time. And anyway, it was also intriguing that I decided I wanted to stay on at CDC. I didn't want to go back and become a pediatrician in New England, which was plan A. I ended up staying in CDC and NIOSH for the next 15 years. And my first immediate job was to switch over to the smallpox program, mainly because that's where billet was located. And Bill Fagey sent me off to Nigeria with Al Noonan for a year to do some smallpox mop-up. Then I spent another year in El Salvador. The reason I got to El Salvador, Lyle called me in one afternoon and said, "Landrigan, do you speak Spanish?" Well, I'd been in El Paso, and of course I knew several phrases, a couple of them suitable for polite company, and I said, "Sí, señor." And he said, "Great." And he sent me off to El Salvador for a year to ride around the country in a Jeep and run vaccine programs. I learned some Spanish. Not too well. Malo y feo. Then I came back to CDC. My overseas adventures had ended. My children were forgetting who I was, and so I had to take a real job. And I joined what was called the Cancer and Birth Defects Division, and we started a new program. We were going to call it the Environmental Hazards Activity, but we were afraid that would draw the wrath of EPA. So we camouflaged the name, and we called it the Special Studies Branch. And so Henry and I had adjacent offices. He was running the Cancer Branch. I was running the Special Studies Branch. I think each of our branches was 2 people, or 3, no more than that, EIS officers. And the place was changing. The NIOSH was coming in. You've just heard. I won't go back over that history. But CDC was starting to grow up. It was by then the Epidemic Intelligence Service program was about approaching its 25th year, and the sole focus on infectious diseases, which had long been the modus operandi, was beginning to shift. And so I stayed at CDC. I worked with Henry, with Ed Baker, with Roger Glass, with Kay Kreis, Dale Morse were some of the key players in that Special Studies Branch. I realized I needed more education because I was flying up to Wisconsin one day to investigate a spill of phenol and having to read about the chemical in the airplane on the way to Wisconsin and thinking this is no way to be an expert. So I got CDC to send me off to the London School of Hygiene for a year. I had intended to take a course in environmental medicine or environmental public health, but it didn't exist. So I took occupational. Environmental was still a few years in the future. And following my return, I was assigned to NIOSH, worked on a number of EpiAIDs up there, health hazard evaluations. And then in '85, I left active duty in the U.S. Public Health Service. Fortunately, I checked the box to remain in the inactive reserve, which I commend to any of you who might be contemplating that decision, and joined the faculty at Mount Sinai. And here, my initial responsibility was to set up, or to build on the work of the great Irving Selikoff, and to set up programs in occupational medicine. So one thing we did was establish unique, to this date the only one in the country, network of centers of excellence in occupational health across New York State. These centers form the backbone of the medical response to 9/11. For my sins, I became a department chair. After 9/11, our department became responsible for annual monitoring of 20,000 of the first responders, the police, the firefighters, the paramedics, and so on. I built a program in children's environmental health, drawing on my pediatrics. I've just the last 2 years finished up producing this massive Lancet, the report of the Lancet Commission on Pollution and Health, finding that pollution in all its varied forms kills 9 million people around the world, making it responsible for 3 times as many deaths as AIDS, malaria, and tuberculosis put together. Spent a little time in the Navy because I missed the fun of being an EIS officer, and because I don't want to retire, possibly not ever, on July 1 coming up this year, I will be moving back home to Boston to launch a new undergraduate program at Boston College in global public health. So how did I what was my involvement with the vinyl chloride episode? It was more peripheral than either Henry or Richard, but because of the life course I took, I had the opportunity to see some of the consequences of the vinyl chloride investigation that played out in spheres beyond the spheres that Henry and Richard have described, and the fact that I worked with Selikoff and became very close to Meltoni, whose name you've already heard. So this was Meltoni, a fascinating character, a complete piece of work. He was a cancer pathologist in Italy. He pioneered what's called the lifetime carcinogenesis bioassay. So typically when an organization, when a research group does cancer testing, they expose adolescent animals, they keep them alive for 6 or 12 or 24 months, then they sacrifice them, they look for cancers. Meltoni said, that's silly. Most humans don't develop cancers until the last 2 decades of their life. Let's let the rats go the whole lifespan, let them die naturally, and then autopsy them. And it turned out to be a much more sensitive means of diagnosing chemically induced cancers in animals. And it was through that methodology that he was able to find that even relatively low doses for the time at least, could cause, vinyl chloride could cause cancer. Meltoni did his work in this castle outside of Bologna, the Castello di Bentivoglio, known to some of the locals as Il Castello dei Ratti, the castle of the rats, because there are hundreds of thousands of rats in there, and the various toxicologic experiments going on. And that castle is today the home of the Collegium Ramazzini. And then this was my other mentor during that phase of my life, Irving Selikoff, a brilliant chest physician who had won the Lasker Award, which is like the Nobel Prize in Public Health, for his pioneering work in the treatment of tuberculosis in the 1950s. Then he had a clinic over in Paterson, New Jersey, an industrial town about 15 miles from New York City. And in the 60s and early 70s, he began seeing workers with these very odd transverse striations in their mid-lung fields on X-ray. End-stage tuberculosis is mostly in the apices of the lungs, up at the top. But these people had mid-lung field lesions, and it was not something he had ever seen before. He was a smart physician. He took an occupational history. He found that all these men had worked in a little factory called United Asbestos and Rubber Company, UNARCO, making asbestos gaskets for the Navy for use during World War II. And he set up cohort studies and made a lot of the seminal discoveries linking asbestos exposure to human cancer. Very excellent scientist, but also a powerful advocate. Well, these two giants of science met at that fateful workshop that you've already heard both Richard and Henry mention, that was convened in May of 1974 at the New York Academy of Sciences to talk about vinyl chloride. I was there also. I was way back in the last seat in the back of the room, just amazed at what was going on around me, not appreciating that this was one of those points in history that could be described as a fulcrum, when these two people met for the first time and forged a powerful bond that resonates to this day. They decided, through their experiences in dealing with the scientists and physicians of the plastic industry, that they needed to form a society in occupational health that was free of industry influence. You have to understand, back in that day, most big companies had in-house physicians. Some were honest, decent guys like Dr. Creech, the physician up at Louisville, who reported the first cases of vinyl chloride monomer that Henry investigated. Many others, to put it bluntly, were shills for the industry. There were people who argued that asbestos didn't cause cancer, that lead was a vitamin. Really, there were people in the lead industry who tried to argue that lead was an essential trace element in the face of studies showing that it eroded children's IQ. So Selikoff and Meltoni decided that they needed to form an organization, small, tightly knit, independent thinkers, not in the pocket of industry, and they created this Collegium Ramazzini, which exists to this day. And this Collegium has become a powerful, independent voice, always based in science, but doing evidence-based advocacy, pushing for change to protect the health of workers, to protect the environment. And I think we've made a lot of progress in some places, although there's certainly a great deal yet to go. And then there were some other long-term consequences of this episode that you've heard described in such detail today. There's no question that the vinyl chloride episode basically brought NIOSH and CDC together. When NIOSH and CDC first came together, it was a shotgun wedding. David Sensor was the director of CDC at the time, a very aggressive guy. He saw a moment of opportunity, and he gobbled up NIOSH. And NIOSH people were not happy at all. They had their institute. They were separate. But the bonds that were forged, the scientific and the interpersonal bonds that were forged in this investigation and in subsequent years, have proven very important and brought NIOSH into the CDC family. These investigations that you've heard described in such detail this afternoon set a standard for the epidemiologic investigation of these rare diseases that wasn't here before. Another consequence, which both of my colleagues have mentioned, but I want to just put in a new portray in a new light. When OSHA required that the vinyl chloride standard be reduced from 500 ppm to 1 ppm, you could have heard the screams of rage and pain from the industry all the way to Seattle. They said it can't be done. We're going to have to move our factories to China. We can't meet that standard. Well, obviously, they did within a year, and I think it was Goodrich who pioneered the new closed-loop technology, where the reactor vessels were cleaned by an internal rotating thing. No longer had to lower people in on ropes to do the job. It actually made them a very handsome profit because they weren't wasting substantial quantities of the very expensive vinyl chloride monomer, which previously had just boiled off to the atmosphere. So this was the prototype, the archetype of a technology forcing standard. That the industry couldn't meet this standard by simply tweaking their process. They had to fundamentally rethink it, put smart engineers to work, stop whinging, and get to work. And finally, one more consequence, which I thought of only too late after I'd already made this slide, is that the vinyl chloride episode illustrates a recurrent pattern, unfortunately, in American public health that we've seen time and time again, that new chemicals are brought to market, are presumed innocent, are put into products, are widely disseminated into the environment, result in the widespread exposure of people, and then, oops, 10, 20, 30, 40 years later, we find out that they're causing harm. We saw this with thalidomide. We saw it with diethylstilbestrol, with vinyl chloride, with polybrominated diphenyls, with phthalates, with bisphenol A right up to the present, organophosphate pesticides, which almost certainly cause prenatal brain damage, despite what Scott Pruitt says. And the way we regulate chemicals in this country has always favored industry over public health, even with the modest legislative advances that were made in 2016. So I think it's a wonderful story. It's a prism through which to see a lot of how environmental and occupational epidemiology evolved in this country, and how CDC fostered it. And with that, I thank you.
Hi. Questions from our online audience. One of our global listeners wants to know, outside of the U.S., how widespread is PVC use, and are there efforts underway to limit its use?
Can you hear me now? I don't know that I can address that adequately, but PVC is still extremely widely used throughout the world. But hopefully, through this early investigation and the knowledge that we've gained from that investigation, and as Dr. Landrigan talked about how the systems are now enclosed, this is a normal practice to enclose systems and keep workers away from the fumes that are causing the disease. So I think that is a consequence that has spread worldwide. And through organizations like the Collegium Ramazzini and others, this message does get around the world. The World Health Organization has an occupational health program that has adopted these same principles that we have recommended as a result of this evaluation, 40 years ago, 50 years ago.
If I might just add a little bit, I did a quick literature survey in anticipation of today's session, and as I mentioned before, the number of cases worldwide of hepatic angiosarcoma tapered off rapidly, and but there still are a smattering of cases that get reported in the 90s and the early 2000s, particularly in Asia from developing countries. So there are occasional cases of hepatic angiosarcoma and PVC that still occur. Very small number, but occasional ones still do occur.
Thank you on behalf of our online audiences.
Yes.
So I'm David Bell, Division of Viral Diseases, and EIS class of 1979. This is just wonderful to listen to this story, and from three luminaries really in the field is even more of a blessing. I had three questions, if you'll permit me. One was, what was the reaction of the company at the time in the early stages of the investigation? It's the occupational health physician, I guess, who called you, so the company must have authorized that, or did they? But then when it came down to the investigation, were they delighted to hear and all arms open, or how did this actually work? And there were other rubber companies and industries, and just at the time. The second question is, were you surprised at all not to find more cases when you did your nationwide search? I mean, I understand there's latency. I understand there has to be intense exposure. But still, from what I heard, or thought I heard, this was a almost ubiquitous chemical in human life, from hairsprays to making plastic and saran wraps. And I guess and here there were three cases at one plant. Were you surprised that there weren't more cases? And the last question is, it's just intriguing that the list of rare cancers that I forget who had a nice slide of this, that were discovered to be caused by common chemicals. And is there a way that somebody suggested making this sentinel system or something? Is that real? Is there a way that can happen so that humans don't have to be the canaries? And there's so many chemicals. How could you elaborate a little more on what you were alluding to? Thank you.
So maybe I'll begin, and then I'll hand it over to Dick and Phil. But in regard to your first question, because I dealt a lot with I did 13 trips to Louisville as part of that investigation. Spent a lot of time with the plant physician, but also spent time with the medical director of the B.F. Goodrich Company. And I think they understood that they had a very tough issue on their hand. My sense of them, in terms of my personal dealings, was they were very forthcoming. So they provided me access to all the files in the company when I wanted cases of this or that. They arranged for me to interview the families of people who used to work there. And I even I had one tense moment at the end of 7 weeks of collecting endless pathology specimens in Louisville. As I was about to leave, sort of the senior-most pathologist in Louisville asked me if I would please hand over all the pathology specimens, because he had a grant from B.F. Goodrich and he really needed to write a paper. And I called the medical director and I said, it's nice that you've given him a grant, but this is work that we've done. The specimens are going to Hans Popper. And they were very good at following through. They supported rather than interfered in any way. I can't speak to the legal issues and whether there were any court suits, but in terms of my investigation, they were as forthcoming as possible. And the second question was, why not more cases? Why not more cases? So, the best I can say to that, these people were very heavily exposed. And I really think it takes a fair amount of vinyl chloride to actually cause the progression all the way to angiosarcoma of the liver. There was an industry-led group that took over from NIOSH, keeping track of all the vinyl chloride-related cases in the world. And the last report I had from them was like 1991. At that time, there were 200 vinyl chloride-related cases. There are several more in the literature. I just think that, these people were so heavy. You imagine these people were effectively anesthetized doing their job. It really took a lot of exposure, I think, to ultimately cause an angiosarcoma of the liver. So we were afraid there might be many more cases, but it sort of topped out at several hundred.
I might address your last question about human canaries. And one of the things that happened was that it really depends upon the administration that's running the country at the time, how things get done. But during the Carter administration, OSHA and EPA and other agencies, FDA, started looking at what we could do. And so an act was put together called the Toxic Substance Control Act, which essentially was that when a chemical was introduced into the workplace, it had to be pre-tested before it came into the workplace on at least animals to see if there was any reaction. Well, it was nice on paper, but it never really got much carried away. And we've just seen in the Obama administration the reintroduction of a Toxic Substance Control Act to update this. Maybe Phil wants to talk about this a little bit more, but we are trying to get pre-testing, and I think that is the answer. How far you go with pre-testing is another question. But one last comment on the companies. I think B.F. Goodrich, their physicians and their company were unique among a lot of chemical companies. And I've worked with a lot of chemical companies, and I've never seen many chemical companies as open as what that company was when these cases occurred. As Phil addressed in his, you see a lot of companies that they want their doors closed and they don't want to share their information with you. B.F. Goodrich at that time was not like that, and I commend them for that. Phil?
Yeah, I'll just add a word on the chemical testing issue. So, to give you some numbers, there are about 80,000 chemicals registered with U.S. EPA for commercial use in this country. There's about 5,000 that really matter. These are the ones that are produced in sufficient volume to result in exposure. When CDC rolls around the country under N. Haynes and does their national biomonitoring surveys, CDC routinely picks up detectable levels of between 200 and 300 chemicals in all of us. Most of them are chemicals that were invented since 1960. The real issue is that only a relatively small percentage have ever been tested for toxicity. As I said earlier, so starkly illustrated by the vinyl chloride episode, chemicals come on the market with little or no testing. In the 40 years that the original Toxic Substances Control Act that Dick just mentioned was on the books from 1976 to 2016, only 5 chemicals were taken off the American market under that piece of legislation in 40 years. It's basically toothless. The new law was passed in bipartisan fashion in 2016 and was moving along very nicely, but there hasn't been much enforcement of late. And chemicals, it appears to me, are again coming on the market with essentially no scrutiny. So humans are the canaries.
You mentioned the vinyl chloride standard before this outbreak was 500 parts per million, or the monomer standard was 500 parts per million. Where did that number come from?
Well, as Dr. Stoffinger, who was with the Public Health Service and was chair of the vinyl chloride, or of the ACGIH TLV committee at the time, often mentioned, these were seat-of-the-pants guesses. Most of them came from the industry, and this is what the industry said they could live with. I know I'm being a little bit not not very optimistic about it, but that's how most of these early standards were set. The industry said, we can live with this number, and we think it'll work, but we don't know if it will, and that's how they picked 500 parts per million. It didn't put their workers to sleep in vinyl chloride at that concentration.
Yeah, it was the anesthesia threshold. Yeah, yeah.
Can I add one additional comment? If no more questions. Just wanted to, just as an update, again, just checked with the cancer program here before. I was curious as to whether there are any new causes of hepatic angiosarcoma that have cropped up since. But the actual background rates of hepatic angiosarcoma, given the population size, have not really changed since then. So there undoubtedly are other causes out there, but they haven't surfaced in any way yet. And maybe the last thing I would add is that Hans Popper was really an exceptional person who later became president of Mount Sinai School of Medicine, but
Founded the medical school.
The medical school. And he actually, Robin might appreciate this, he actually was a resident at the Lawson Army General Hospital, which is now the Chambly campus, during World War II. And his family, they were Jewish, they were in Austria in 1938. His family was told they had 8 hours to leave Austria. His father was a cardiologist. At age 75, came to this country, did an internship at Cook County General Hospital, and Hans Popper ended up being a resident on the Chambly campus, taking care of evacuees that were flown into Peachtree DeKalb Airport. So he actually had a connection with our work here at CDC. Okay, thanks.
I just want to say in closing, I just want to thank CDC, the institution, and all of you, because CDC changed my life. There's no way in the world I would have done what I have done if it had not been for my experience as an EIS officer. So thank you very much. Lyle.
I would echo that CDC changed all of our lives. NIOSH didn't want to become part of CDC, but we did. We came kicking and dragging, and they dragged us in, but it's been a better world since we came.
And I'd like to thank all of you for joining us, and I'd like to ask you to thank the speakers for their phenomenal presentation and their work. Thank you. And also, if you want to know a little bit more, the library has a display downstairs on the polyvinyl chloride and the angiosarcoma investigation. And thank you again for coming and for tuning in. And we'll see you for the next We Were There in August.